haven't done this in a long time.
Yeah, I know. All right.
I have to get really close, right?
Yeah. Is that a good level? Do you need to
No,
be lower or
I need it
higher?
to be lower.
Okay. Yeah.
And I
And
just
then you can just angle it up.
do re mi fa sol la ti do re fa sol la ti do mi fi re fa la ti ti.
Oh, yeah.
Then
I
no,
forgot.
what do you want to do? Then you do when you know the notes to sing. You can sing most anything.
Yeah.
Okay.
That was good.
Okay.
Well, hey, y'all. Welcome back to another episode of Your Mom on Drugs featuring me, Josh Klaus.
And me, Jennifer Seltzer.
Yes, we are a mother and son pair who like to talk about the world of medicine, pharmaceuticals, biology, things that can be taken when you're not feeling so hot. And today we are going to be talking about chickenpox and shingles. And you're probably thinking, what do those two things have to do with one another? Well, that's what this episode is all about. Just to give you a little background on ourselves, if you're a first time listener to us, my name's Josh, and I have a master's in public health and a bachelor's in biology from the University of Texas. And I'm also the son to this wonderful lady right across from me, who I will let introduce herself.
My name is Jennifer Seltzer, and I am Josh's mom. And I have a bachelor's in pharmacy, but I also have a doctor of pharmacy degree as well too. And I practiced and taught pharmacy students for several decades. I'm now retired, but I was primarily, my focus was drug information and helping students learn how to acquire information about medicines and disease states and also evaluate clinical trials. So.
And funny, growing up with my mom, I always thought that what she had was just general mom knowledge. I had no idea that she was so trained and knowing about all the things drug related. It wasn't until I was about 15 where I saw a letter addressed to Dr. Seltzer. And I was like, who's Dr. Seltzer? And then my mom was like, that's me. And so it reflects poorly on my curiosity of my mother's career. But now that she's retired, I wanted to pull her out of retirement and talk about drugs and diseases that affect humans. So I figured we could just jump right into it and talk about shingles and chickenpox. And it's a viral disease that causes that, right? Do you want to give an overview of...
Sure. So we can't really talk about shingles without first talking about chickenpox. Or chickenpox is known as the varicella zoster. That's the varicella zoster virus. And it used to be before 1993 that all of us would get the chickenpox. And if you remember, it was a disease state that was very contagious, and it had a generalized itchy rash that was usually covered the whole body. You usually have symptoms for 4 to 7 days. And usually it was an exposure to someone who also had the chickenpox or the varicella zoster rash. You would incubate about 2 weeks before you'd start seeing evidence of that particular rash. Sometimes as parents, you'd have like chickenpox parties so that everybody would get the chickenpox and get it over with and stuff. So usually adults will get a little sicker if they got chickenpox, if they didn't get it as a kid. They may get fever and kind of just feel kind of sick before the rash develops, whereas kids usually break out with the rash. They may have a day or so of fever and then just feel kind of yucky. They can have a fever. I mean, they can feel kind of yucky for a couple of days. And then, it takes about a week or so for all of those little vesicles that have caused itchy and, develop the rash to crust over. And once they've all crust over and, especially after they've crust over, then you're considered not contagious anymore. You do spread the chickenpox primarily by direct person contact. You can inhale, like even the bacteria. The viruses can be emitted from the lesions themselves, so you could breathe that in potentially and get it. Or certainly if you also if somebody's infected and they cough or whatever, you could also potentially get it from them as well that way. And then after that fact, so a lot of times we get viruses and then they're gone. But this particular virus stays when you're done with the chickenpox virus, then it stays what we call dormant or it's kind of asleep in your basal root ganglia, which is inside your nervous system near your spinal cord. And it stays there for years. And so we're going to then now turn our attention from that point on to talking about shingles, because shingles is the reactivation of that virus in your nervous system. And it primarily occurs in adults, but it can also occur in kids, but kids don't seem to develop as many of the big symptoms like adults do when they get shingles.
Yeah, before we head into shingles, can we stop and maybe talk a little bit about chickenpox and maybe just basic viruses real quick?
Of course.
All right. I think viruses are really interesting because they're one of the smallest things on planet Earth that kind of act like an organism, even though they're technically not alive. That's a whole nother debate. But just to give everybody a concept of like what a virus is and kind of what my mom was talking about, going from that dormant state to the active state. So all a virus is, and we'll post a picture on our Instagram just so you have a good idea of what it looks like. But it's good to picture a virus kind of like a house. Like if you look at a house, it's got an outside structure, but there are ports of entry. There are doors, there are garage doors, there are windows. And with the right combination of tools, whether that be a key or even some mechanical force, like lifting up a window, sometimes you could even break a window. Don't do that. And you can get into the house. But also remember, inside of the house, there are also doors that might lead to closets or bathrooms or bedrooms and things like that. So the cell is a similar way. And the virus is basically trying to trick the cell into getting inside of it so that it can make more of itself. A virus is incapable of making more of itself. So it actually has this really cool coating on the outside that it has all of these proteins on it that we call antigens. And then they will try to bind, with a cell. And if it fits just in the right way, it'll trick the cell into letting it inside of itself. Now, a virus is just composed of this outside coating, basically just almost like it looks in this case with varicella, it's actually a herpes virus. So not the herpes that you probably know from sexually transmitted diseases. Herpes is just a big family of viruses, actually over 100 types of herpes viruses. And they come in, I think it's alpha, beta, and gamma, I think just based on their protein subunits. So varicella actually falls under alpha and it's just one type of herpes virus. So basically it has this really cool, almost looks like a basketball, like a shell-like virus. And then it dumps its genetic material inside of the cell, and its genetic material is actually DNA. You might have heard this because all of your cells have DNA, and that's how your cells know how to make protein. So it actually puts its DNA inside of your own cell, and then your cell just sees that DNA and incorporates that into its own genome, which we call basically the library of all of the DNA inside of your cell. And then it just starts to make copies of this virus just without knowing it. And it will just make copy after copy after copy after copy. And then soon there are so many viruses inside of the cell that it literally explodes. And then that's just one cell. And now you have so many other viruses then going out to each other cell and doing the exact same thing. But if you know anything about your body, and hopefully you know a little bit, there's this thing called the immune system that's kind of sniffing around to see if any funny business is going on. And if enough of this virus goes around causing enough trouble, your immune system goes, hang on, wait a minute. And they actually bind to these viruses using a lot of different mechanisms we won't go into in detail here, but they will basically try to gobble them up and degrade them before they can cause any more damage. So when mom is mentioning when you get something like the chicken pox and you get a fever and tiredness, that's not really the symptom of chicken pox. It's actually partially the symptom of your immune system attacking this virus. And the fever is actually raising your temperature in your body to actually reduce the ability of the virus to move as quickly, because actually the temperature affects the biochemistry of certain foreign pathogens. And so a lot of times when you feel feverish or malaise or any of these symptoms, when you get infected with something, it's actually your own body fighting against it. And then these secondary symptoms, things like the pustules and rashes on your body, or what's actually specific to the virus itself. So just to remember that all a virus is just a protein coat with genetic material inside of it. It's trying to get inside of your cells, make more of it, and then move on and do the same exact thing. So, and last thing I'll say, because I'm going on a virus diatribe here, is that my mom was talking about this dormant phase. So viruses do this really cool thing where they can go from something called the lytic cycle and the lysogenic cycle. So the lytic cycle is what I describe, where the viruses are just going crazy and they're trying to replicate. But then that they come to a risk of like, well, if I do that, I'm going to get found out by the immune system. And they're not consciously thinking this. This is just something that happens. So every now and then, a virus will just insert its genetic material into a cell. And as my mom said, in the case of varicella, it inserts its DNA into nerve cells associated with your spinal column, and it will just stay asleep, meaning that it won't replicate itself. Your cell will just think that's a part of its genetic code, and it'll just stay there. And it lies dormant, almost kind of like a monster waiting to come out at the perfect time. And when that perfect time comes out, which is what we're going to talk about with shingles, and we still don't really know the environmental trigger that causes this, then it reemerges in these ganglion cells, and then you get shingles. So I think this would be a perfect segue to then talk about, shingles. And it's the same exact virus, but just in a different location, correct?
That is correct. So it is, interestingly too, when you look in the literature with the chickenpox virus, they'll call it varicella zoster. But with shingles, a lot of times you'll see it as herpes zoster. But as Josh said, it's all in this. It's the same exact virus. It's just a way to differentiate from the fact that it's not chickenpox anymore, but now it's shingles. And what happens is that at some point, as Josh said, that virus that's been sleeping around in your ganglion cells in your nervous system for years decides to awaken and activate. And then it will then start producing the symptoms of shingles. Let me just give you just a little bit of just kind of background information about shingles. First of all, shingles is not a seasonal infection like some viruses that we know about, like the flu, for example, so it can happen at any time during the year. It also is that for all of us that were born before 1980, almost all of us are infected with this wild type of we would call the wild type varicella zoster virus, and we're all at risk for shingles. And about 1.2 million cases of shingles happen each year in the United States, where about 1 in 3 people will develop shingles in their lifetime. And usually most people only have one episode, but you can have a repeat episode of shingles. More often we see that in people who are immunocompromised. That means people whose immune systems may not be working at optimum, levels due to either a disease or medication that they're having to take.
So that means that you said from 1980. So almost the majority of people born from before 1980 or have been infected by
the wild type, right?
Yeah, the wild type varicella.
Right.
So there's probably, I was born after 1980, but I know I had the chickenpox.
Right.
Because you told me I did.
Yes.
And you were born before 1980,
yes,
correct?
I was.
Okay.
Rub it in.
Yeah. Well, I hope so.
Yeah.
So it makes you think, wow, like a lot of us are just walking around with this virus inside of us and we don't even know it.
Right.
Right. And it's just lying dormant.
Right.
Okay.
Exactly. So, interestingly, so we're going to, I'll get back to that point in just a minute, but so the risk of developing shingles increases as you get older. And one of the reasons one of the speculated reasons that this happens is because, again, as you get older, your immune system is not working at the capacity it was when you were a 10-year-old or a 20-year-old. So it doesn't work quite as well. So it could be that you don't have your immune system that's going to target that varicella zoster virus working as well as it used to and stuff. So that's one reason.
That's a good point. Yeah. One of the best analogies I heard was from a physician. His name's Peter Attia. And I highly recommend folks listening to his podcast called The Drive. It's really good medical information. But he likened the immune system kind of being like using the house analogy that I used earlier. The immune system is kind of like an army going around to each person's house to kind of show proof that nothing nefarious is happening on the inside of that house. And if that house can show the proof that nothing nefarious is going on inside, basically they show their protein content, say, see, no virus here, then the immune system moves on. But if there is any evidence of virus activity, or even if the cell can't even produce any activity, the immune system will kill that cell. So even if it's jumping out of that lytic to lysogenic cycle, or from lysogenic to lytic, if your immune system is young and healthy and robust, obviously you're not going to notice that you have symptoms, even if one of these varicella viruses comes out. But as my mom was saying, amongst elderly people and immunocompromised people, if your immune system starts to, if your military starts to dwindle a bit and it gets a little aged, and over time, then the virus might get a little more adventurous and might actually go out and start to copy itself. And as we know with certain viruses, they usually grow exponentially, because if one cell can explode and make 100 viruses, and then that 100 viruses infects a cell, and then it creates 10,000. So it's an exponential growth thing. So just keep in mind, your immune system is doing a lot of work in the background and you don't even know it. And it's an amazing feat of biology that you can keep a lot of these things at bay. So, yeah.
Right. And I wanted you to clarify for our audience, Josh, I think that you might have missed defining what the lysogenic stage is. So lytic is more like the viruses collect inside of a cell and it explodes, but lysogenic is more that they kind of go dormant.
Yes, it's that dormant stage. Sorry, I forgot to mention that.
Yeah. So okay. So as Josh said, so there's a couple of reasons why our immune system may be declining. One is especially they've seen that happen in people who are beyond 50 years of age. It started, to kind of decline more than when you were younger than that. That doesn't mean that if you're younger than 50, you can't get the shingles, but it's less common. And also to people that are immunosuppressed, either you've got a medical condition that suppresses your immune system, like if you have cancer or a human immunodeficiency virus, or you are taking immunosuppressive medications, steroids, some drugs like for rheumatoid arthritis that can suppress your immune system. If you're a bone marrow or a solid organ transplant patient, you're going to have a lower immune system. So those kinds of things would make you more susceptible to getting the shingles. It's interesting too, I read in the literature that I read, it talked about the fact that there seemed that more women developed shingles than men, and more whites compared to blacks, but the reasons for this aren't really well understood. And so I think that it's just collecting data over time just to see how that really pans out. Interestingly too, most patients with shingles have no history of being exposed to somebody with a herpes zoster's virus infection, unlike the chickenpox vaccine, because remember, the shingles is already there inside of you. So it's not that you got exposed to somebody else. It just decides to wake up for, the fact that your immune system might not be working as well, or it decides to replicate. So
yeah, that's a good point. So it's almost like people who had the chickenpox might know that they might get shingles in the future, but there are people who are infected with varicella who might not have gotten the chicken pox, but then could develop shingles in the future, right? Like if you're infected with this virus, there is a chance, even if you didn't develop chicken pox, that you could develop shingles.
I think that if you didn't, I don't know how you could get that virus without having been exposed. Now, maybe you had chicken pox and I don't even know how you could have chicken pox without even having any symptoms.
I guess what I mean is like, could you have gotten such a low level of virus inside that it didn't present symptoms?
I did not read anything like that.
Okay.
I mean, I did not read anything like that. That doesn't mean that it's not possible, but that would be, I think, pretty unusual and stuff. So, but
so it seems more likely that if you'll have enough of a viral load to cause chicken pox.
I'd say that if you by chance as an adult, let's say you're an adult my age, and somehow you skated through not ever getting chicken pox as a kid, and you get exposed to that varicella zoster virus, the first thing that's going to happen is you're going to get chicken pox. You know, so yeah,
because from what I read, it goes into the areas of the body that are more associated with like the epidermis. So like in mucosal linings, which is what causes the pox for chicken pox.
Right.
And then it migrates just because your body is composed of blood and fluid and the stuff moves around. So the virus eventually finds a home. It's like, oh, I really love these ganglia. You know, I'm going to nestle down here and stay a while. Why it resides there, that's a good question, but maybe it just has the right receptors to reside there. Remember, just for those out there, ganglia just means a collection of nerve cells. So it's like a bunch of them combined together. So a single nerve cell is called a neuron, and then a bunch of them together is called a ganglion. So it's just a mass of those nerve cells. So I think I detracted you from your point, but you were talking about, essentially with people who get shingles, they have to have an event before, correct?
Right. Okay. Right. And so let's talk a little bit. So we talked about chickenpox and how chickenpox presents. Well, shingles presents differently. There is, so again, we talked about the fact that this virus kind of lays low in your ganglion cells, which are nerve cells, and they kind of line your spinal cord. And your spinal cord has different types of nerves that go out to different parts of your body to make things work, for you to feel things, for you to move, all that type of stuff. And so there is a patterned picture of how our nervous system kind of talks to the other parts of our body, and it's called a dermatome map. And so basically it shows how our nervous system, or the nerves that come from our spinal cord, talk to the different areas of our body. And our spinal cord is broken up into separate sections. There's the cervical section, which is at the top. Then the thoracic section, which is kind of your midsection, and then the lumbar section, which is at the bottom. And so when your shingles gets activated, and it does its thing, primarily we're seeing it have activity in that thoracic area, which is in your chest, kind of mid area to the lower part of your back as well too. And the reason this is important for somebody to understand this is that when you get the symptoms of shingles, they are going to be located in a specific dermatome, and which is going to just line up. And it always goes just on one side of your body. It doesn't cross what we call the midline of your body.
Really? So it's always one side of the body?
And unlike the chickenpox, where it goes all over the place, when you get a shingles infection, it follows a dermatome. And the symptoms start out, first of all, with maybe feeling some tingly or burning pain, and it could be throbbing, and it'll be because it's following along this dermatome. And if Josh, I can give Josh this picture, and he can also post this picture of the dermatomes on our Instagram as well too.
Is a good analogy to think about a dermatome as like, if you're thinking about like your spine is the trunk of a tree, and then each one of the branches off of a tree is essentially like the nerves going off of that. and essentially the shingles would just be affecting one side of the tree. Is
Yeah,
that a good
one
analogy?
limb on
Or
one
one
side of the
limb?
tree. Exactly.
Okay.
That's a great picture. That's a great picture. And so what happens? So you've got this little tingling, burning pain that you feel, and you may have some associated systemic symptoms as well. You could have headache or malaise or fever. But then once with that burning pain, then a few days after that, then you're going to see this vesicle eruption. This you'll get like a red kind of rash, and then it becomes then a pustule, like it's a bump filled with pus kind of, and then it's called, after that it is called, so it has a pustule. It's a pustule vessel first, and then it ulcerates. So it may kind of like the pus thing but bursts, and it's kind of like a hole kind of thing. Just we've all had that kind of stuff happen to us before, and then it crusts over and stuff. And so it takes about, and usually we'll see those that pustulating and ulcerating event happen 3 to 5 days after the rash has started and stuff. And it usually takes about 2 to 4 weeks for that rash to heal. So that's 2 to 4 weeks. And you may have some pain associated with it as well. So you're fairly, and you could have some systemic symptoms as well too. So it's a fairly uncomfortable and kind of nasty looking kind of rash and stuff. So it's not a very pleasant experience at all.
And it doesn't seem like there's any warning signs. It just kind of, for some reason, the virus just decides to break out of that lysogenic or dormant phase into the lytic phase in this specific dermatome in your thoracic portion of your spine,
or your lumbar,
or in your lumbar.
Now,
Okay.
now most of the time it happens there, and I'd say probably the warning symptoms of it are going to be that prodrome, where you start feeling that burning pain. That's really weird. It's just kind of following, a path along, a nerve, either in your back or your lower back. Or
is it always just one side of the body, like meaning like it's always going to be the right side, or does it
no? It
depend
can be on
the
either
person?
side
Okay.
and any of the dermatomes. But it's not going to cross over to the other side.
Gotcha.
If you've got a matching dermatome on the other side, it doesn't cross to the midline. So
Okay.
does that make sense?
It does. Yeah. Wow.
Okay.
What an interesting virus.
It is. It's quite fascinating. And you can, like I said, you can have, fatigue, fever, feeling kind of sick, just kind of that malaise accompanying along with it. Most of the time, this virus gets diagnosed clinically, so that you're not doing a blood test per se to test it. The only time you would usually do that is if you happen to be someone who ended up with the pain, but there's a small percentage of patients that can get the pain associated with the shingles virus, but don't get the rash. And so then you've got to figure out, because they've got to do a diagnosis. And so there are some tests that can be run at that point and stuff. So again, we talked about the fact that this virus as shingles causes a nasty kind of rash that starts out red first and then turns into pustules and then ulcerates and then crusts over and is associated with some pain. And so it usually takes, like I said, about 2 to 4 weeks for it to heal. There are some complications that can be associated with this virus. One of the most common ones is what we've heard of is called post-herpetic neuralgia. And basically that is pain that persists after that rash has gone away.
It's almost like phantom pain.
It almost is.
Yeah.
And it can continue for it's usually any pain that happens and lasts for about anything that lasts greater than 4 weeks, after the rash is gone. And I mean, I don't know if I'm saying that right. If the rash lasts and heals over at 4 weeks and you still have pain after that, then we're going to call that post-herpetic neuralgia.
Because it doesn't seem that there's an apparent cause for the pain. It's just almost like the remnants of the nervous system kind of overfiring.
Because it was in that ganglionic type cell, because it's in the nervous system and stuff. So,
and just as a refresher, a lot of sensations that you feel inside of your body are due to your nervous system firing. It's a way to process sensory information. This is a really brief side tangent, but I when I took some neurobiology classes in college, we learned about this surgeon. His name was Wilder Penfield. He was this Canadian surgeon, and he was one of the first surgeons to do open like brain surgery while somebody was conscious. Fun fact, your brain has no nerve endings, meaning that you can poke it and you will not feel that your brain is being poked. It's your central nervous system. But the crazy thing is that he took a electrode, which is basically provides electric current, and he would stimulate different portions of the brain and then ask the patient while they were awake, like, hey, what are you feeling right now? And sometimes they would feel somebody touching their arm if he was touching a portion of their brain, or sometimes he would do it and they would hear music. And so there's this really cool idea that your brain is responsible for getting signals from the periphery of your body, like your fingers and your toes, like you're experiencing the world through your digits. And then your brain has to make sense of that information. So if you have this virus that is essentially sending quote unquote phantom signals because it's causing inflammation to these nerve cells or these ganglion cells, then your brain is just thinking, oh, we're experiencing pain. And so it's just going to keep delivering that symptom even though the cause, quote unquote, the rash is gone. So it's just like this nasty little trick that unfortunately that varicella is playing long after it has caused its initial damage. So just a fun little side tangent.
Yeah,
Well,
thanks,
it's not that
Josh.
fun.
Yeah,
but
yeah. But that's a good picture of what's going on. And this post-herpetic neuralgia, or PHN, can happen in up to a third of the patients. It can go anywhere from as low as 5% of patients up to about a third of the patients can have this hanging on after they have the shingles rash. And the risk of getting post-herpetic neuralgia does increase as you get older. The other thing is that although a lot of shingles viruses occur in those thoracic and lumbar pathways from your the dermatomes in that area, you can also have it affect other dermatomes. And one in particular is one that affects your eyes. It's called the trigeminal nerve. And so it's going to be in the upper part of your spinal cord. And if you get ocular complications with shingles, it becomes almost a medical emergency because you can lose your vision if somebody does not take care of it very quickly.
I think we learned about the trigeminal nerve in our migraine episode too, right? Because I think the trigeminal nerve is affected within migraines with the
Yes.
aura, correct?
Yes.
Okay.
Yes. But when the trigeminal nerve is affected by the shingles virus, you can get things like a conjunctivitis, which is kind of like a pink eye.
Another episode.
Yes. Or it can cause glaucoma, which is increased pressure in your eye. Or again, like I said, blindness if you don't treat it. So you want to get to an ophthalmologist right away if you ended up with eye complications or eye symptoms associated with your shingles virus.
Okay, that's really good to know.
Other complications of the shingles virus include the fact that it could disseminate or spread throughout the whole body. That's not very common, only in about 1% to 2% of patients. And then you can also have sometimes a bacterial overinfection or superinfection, but that again is not very common as well too. We talked about the fact that chickenpox is very transmittable and about chickenpox parties in the old days and stuff and all, but also the shingles virus can also be transmitted to other people if they have not had the chickenpox or they've not had a vaccine and have never had the chickenpox. So again, the virus can be transmitted to other people in people who have never had the virus before.
Gotcha.
Okay. So we're going to now transition into the treatment modalities for shingles, because if you get it, then you're going to want somebody to help you with some of the different things that go along with it. The first thing that has been prescribed or recommended for use in shingles vaccine, in the shingles virus disease infection are antivirals. So there's several antivirals that are recommended. They should be used as early as possible in the disease state in the first 72 hours, so the first 3 days. And what the reason for the antiviral is you want to hopefully speed up the lesion or those vesicle, them getting better and resolving. You want to decrease the number of new lesions that develop. You want to also reduce viral shedding so that it doesn't spread as much. And you also want to hopefully decrease some of the severity of the acute pain. It also may help to prevent ocular complications or the eye complications, and it may help to decrease that post-herpetic neuralgia risk. So the antivirals are important to give if you do get shingles in those first 72 hours. The most common ones that are used are acyclovir, valacyclovir, and famciclovir.
And I assume that these are either prescribed by a doctor. You probably get them at the hospital,
prescription.
right?
No, you can get an oral prescription for them. They're all oral medications, so you can get a prescription for them and get it filled in your pharmacy and take it. And usually you take them for about seven days. If you have really serious symptoms associated with your shingles infection, then you might have to be hospitalized and receive some IV therapy.
Yeah, and because with either chickenpox or shingles, what time you're getting them, taking an antiviral, it's probably better to send somebody else to get the antivirals, just because because it can be spread via these, openings in your mucosal lining, or even in droplets if they get out. It might be good to send somebody else to do it. Also to get it relatively quickly, because viruses, as we know, spread, or they replicate really quickly. An antiviral is actually meant to slow down that replication process for viruses, so your immune system has time to catch up and to the load that the viruses are causing inside of the body. It's like you're I don't know if you remember that story, like when the Dutch boy putting his finger in the dike, and you're essentially, that's essentially what antivirals are. You're trying to stop the flow so that you have time to repair, because you don't want that dam to break, because then it takes a lot of energy and effort for your immune system to clean up after that.
That's a great picture as well too, Josh. So the other thing, so you're going to want to try to address the actual virus itself, but you may want to take some medications for pain relief, because the pain can be, I've not had shingles myself personally, but I hear that it can be quite uncomfortable. You can take over-the-counter pain relief medications such as Tylenol or Advil or Motrin. Sometimes they work and sometimes they don't. They can for sure help you if you have a fever or just the malaise part of the virus. They can help with that. The other things that are used to help with the pain of shingles are, there's a topical cream called capsaicin that can help with the pain of shingles. And also you can get lidocaine patches, which is kind of an anesthetic, or not kind of, but it is an anesthetic, and it can help with the pain as well too.
Fun fact, capsaicin is the molecule associated with spicy food.
That's right.
Yeah.
It is.
It's
That's
wild
right.
that you can also use that topically to actually soothe the pain, because I hate spicy food. It gives me so much pain.
Yeah.
But if I imagine putting it on the outside of your body has a different
Yeah.
effect.
Yeah.
It's amazing. Context matters when you're putting molecules in places.
That's right. That's right. Other things that are used to manage the pain that's associated with the shingles virus infection are, some patients actually do need narcotics. So things like opiates, oxycodone, morphine and stuff, because the pain can be pretty severe. Other things that have been used to manage the pain associated with shingles are gabapentin and pregabalin. They are actually anti-seizure medications, but they have mechanisms that have been proposed anyway to have some chemical interference with the pain mechanisms that are going on in your nervous system. So that's why they could potentially work. And then they've also used antidepressants too, to manage the pain associated with shingles. And patients that are kind of resistant to these effects, there also have been some studies where they use botulinum toxin injections to help with the pain as well too. So that's not going to be the first line therapy. That's going to be kind of towards the end and stuff. So.
Yeah, because then imagine having something like PHN is got to be, dealing with chronic pain has just got to be awful.
Yeah.
So you're kind of like, well, how I know I've been in pain for a long time, and it affects your mood.
It does.
So I imagine sometimes maybe it's not even just about the pain; it's about learning how to bear the pain.
Right.
Because that can be really tough.
Right.
So he just wanted to end. And it's like, well, can I bear it not ending, knowing that this has happened?
Right. And that's a good point. I neglected to mention this, but this post-herpetic neuralgia pain can last for months. And I've even read that in some patients it could last for years.
Yeah, it's
So
awful.
it's bad.
Mm.
That's I mean, so in that, 30% or so of patients that get it, it's a bum deal. So
And on a lighter note, one of the other great treatments for shingles or chickenpox is oatmeal. Oatmeal baths. Are you just about to
I
get
was
to
just
that?
about to get to that
Yeah.
and stuff. So yeah, so there are some other things that can be used to help reduce. It's primarily to help with reducing the itching that might be associated with it and stuff, or just to just bring just some relief. I can remember when Josh and his brother had the chicken pox. There were oatmeal bath, and they stuck them in there, and somehow they felt good while they were taking that bath.
Well, I actually looked up the history of this because I
Okay.
was really curious about why oatmeal of all things. And actually, it's been used since like 2000 BC in
Oh,
like the
wow.
Egyptian times.
Oh, wow.
It's just been kind of known to kind of cause this soothing effect. And long story short, like this is just a side little like food chemistry thing. When you boil oats, very much like when you boil fruit, this is how you make jelly or jam. It's like when you boil fruit, you release these things inside of the fruit, what's called pectin. Essentially keeps the binding of the cell walls, because plants are made of these things that are a little bit different than animal cells, and that really helps them stick together. And so you basically get this kind of, we call it a colloid. It's a colloidal solution, which is almost kind of this gel-like solution where things are just kind of suspended in animation. If you've ever seen Jello before and things suspended in that Jello, that's a colloid. And so very much like when you boil fruit and you kind of get these together. And actually that's the difference between jelly and jam, is that one has pectin and one doesn't, which is why jam is more spreadable and jelly isn't. I might have that backwards. Please
No, I think that's correct.
me.
I think that's correct, because the jam has the actual pieces of fruit in it and
Okay,
stuff. So
well, there
yes.
you go. And so same with oats. So like when you boil them, actually a lot of these properties get leached out and they go into the water, and they kind of into this colloidal solution. And so when you apply them to the skin, they have this anti-pruritic, that was a fun word that you taught me, pruritic, which basically just means itchy. It's P-R-U...
RITIC.
Yeah, pruritic. You can impress people that next time. And so it has this kind of soothing quality. So when they found this out, now they put it in a lot of cosmetics. They put it in shampoos and lotions, because they found out this property of oatmeal not only is anti-itch, but it also makes your skin feel a little creamier and smoother. And so it's also now probably in a lot of products you use to make yourself feel nice and vibrant and young. So yeah, I thought that was really interesting.
There you go. In addition to taking an oatmeal bath, the other things that you could use potentially to help yourself feel better, you could put some wet compresses on the area of the rash or where the pain is, to just help it feel better. You don't want to use the wet compresses if you've also put a cream or a patch on at the same time. You could either wipe it off or just, minimize, reduce the effect of the cream or the patch. So again, they're used separately. There's an old time favorite. It's like in the pink bottle, the calamine lotion. You could use that for, reducing itching, or just apply some comfort to that area. And then also wearing loose clothing, because can you imagine if you're in pain and then you've got wearing like leggings, then that would not feel very good. So you're going to want to use that light, loose clothing, to help feel better and stuff. So you want to make sure you keep that rash clean and dry. And you don't want to put topical antibiotics or adhesives on it. You don't want to close it up, because that's not going to be good for it and stuff. So no, you don't need to use topical antibiotics and stuff, because that's not going to help it get better, because an antibiotic does not treat a virus.
Yeah, antibiotics are for bacteria. And unfortunately, this is not a bacterial infection. So those are mechanisms for when you have shingles.
Ways to treat the actual virus itself. So now we're going to move into, well, is there anything we can do to prevent the virus?
Right.
And obviously what's been developed is a vaccine.
Yeah. And we are very aware that vaccines are a little bit of a hot topic nowadays. And we understand, if y'all listening to us might have a different view of vaccines. We are just kind of under the view that, when we read the literature, that we are making the assumption that these are developed in a safe and effective way that have been evaluated by organizations like the FDA. And we are just basically, we're not experts. We're trained in a certain field, and we are kind of going into the medical literature and just reporting what we find. And that we want y'all to make the best health decisions that you can make based on the information that we find. But not every condition out there is preventable, so it's kind of cool that we have a technology that can at least provide some type of preventative strategy. Because certain things like cardiovascular disease or cancer, like there are behaviors that you can do to maybe reduce the risk. And that's another thing I want to talk about too, is the idea of risk. So risk, a lot of times when we deal with the medical literature, we're dealing in things called probability. And probability is the idea that there is a certain likelihood of something happening to you. So for example, if you have, let's say you're driving in a car and there is a 90% chance that you are going to make it to your destination safe. That does not guarantee that you're going to be safe. There is a 10% chance that you could not arrive safely at your destination. And it is I'm making up these figures, by the way. I think it's much safer than that. But there is a chance that you could not make it safely. But it's up to you to say, am I going to get in the car today? And then if you get in a car accident, should I wear my seatbelt or not? To prevent major injury. And you could arrive at your destination without your seatbelt on and be safe. But you could also get in a car accident, and if you don't have your seatbelt on, you'll have an adverse outcome. Will you die? There's a chance you might. And so when we talk about probability, we're just talking about likelihood of events, because unfortunately we're humans and we don't have perfect information. And so probability basically comes into light when we have imperfect information. We say, based on these assumptions and these things that we do, this is the outcome. Like, this is the likely outcome, whatever that percentage may be. But there could be a percentage of people where that outcome is not favorable. And that could be for myriad factors. So when we're talking about vaccines, if you got vaccinated and you still got the shingles, for example, it could be because the vaccine was bad. It could be that your immune system didn't respond as favorably to it. It could be the fact that the certain type of shingle, the varicella virus, just overtook your immune system. So when we talk about adverse events, even when you get a health intervention, just like people who never smoked a day in their life can still get lung cancer. There's still a probability there, even though it's very low. So I just wanted to kind of give that as a caveat. I don't know if you want to add anything on to that.
I know. I think you covered, most everything I think that needs to be said about that. So,
okay. Yeah. We're here to provide information. You're your own person, make your own choices, and we love you. So,
and on that note, I'm going to talk about the shingles vaccine, because the shingles virus, the effects of that dormant shingles virus is preventable with a vaccine. There was a vaccine that came out initially against the shingles virus in 2006. That was the first one that came out, and it was a single dose virus. I am not doing well with words today.
Words are hard.
It was a single dose vaccine. It came out in 2006, but then since that time, it was shown that it was not as effective, and that was a big deal. It was a single dose, but it wasn't as effective. And so it has since been replaced.
I think it was 68% effective
it was
at reducing the risk?
And it dropped to 40% effectiveness in people over 70 and 15 or 18% effectiveness in people over 80. So again, it was like almost like it didn't provide a lot of benefit and stuff as the older you got. So that was a bummer, so.
Yeah. I just want to, sorry to do another tangent, but I feel like maybe it might be a good idea to just do a basic overview of what a vaccine actually is or what it does, since we haven't talked about it yet.
Sure.
So the theory, and please fill in my gaps if I've forgotten, but your immune system, when it encounters a pathogen that it's never seen before.
And a pathogen is bacteria or a virus.
Fungus.
Something that's not welcome in your body.
Yeah,
So,
that's going to cause some type of disease. And if it's never seen it before, it doesn't know how to respond to it. Remember with our house example, it's like if it's showing a key that you don't have a lock to, there's no way to get that door to open up. So if there is a virus or a bacteria that's in your body, your immune system can't identify it. So it'll essentially just run rampant, cause a disease. And then your body learns if you survive that, okay, this thing caused a bad thing inside of us. Let's learn next time it comes inside of us to sniff it out really, really quickly. So your body has this whole host of tools to be able to fight against this, things like antibodies and white blood cells and macrophages and T cells. And that's beyond the scope of my knowledge and understanding, because there are immunologists out there.
mine too.
Yeah, who are great at this. I would highly recommend listening to a podcast called TWIV, This Week in Virology, who are amazing at just talking about viruses, and they are so awesome, and they just really do a great job of talking about this. So the goal with a vaccine is like, well, what if we give a small portion of the virus so that your body kind of knows what to expect prior to being infected? And this technology can take many different forms, and we're going to talk about that. My mom just talked about a lot. You can give people an attenuated version of a virus, meaning that it's actually the whole virus is inside of it, but it's been killed, so it shouldn't be active or alive. But now our vaccine technology has gotten much more sophisticated. We can even take some of just the genetic material that was inside of the virus and say, well, this is the part that seems to be good that the immune system can sniff out. And we call those subunit vaccines or recombinant DNA vaccines. And you've probably heard about maybe in the coronavirus pandemic, we've also had mRNA vaccines. We won't get into that as well. But there are many different ways to try to get your body to become prepared for a pathogen coming inside of your body. So yeah, going back to what we were talking about with the initial shingles vaccine, what my mom was saying is that the first version, I believe you said it was a attenuated virus.
The first one was a live virus vaccine.
Live virus. Whew. Okay. Yeah. So there was even a risk maybe of, even getting some live virus inside of you as well. But I think the assumption there was that the dose would be low enough that it wouldn't cause pathogenicity. Correct?
That's correct. No, I'm good. I'm good.
So going back towards that vaccine, were you done talking about that? The first one that we came out with, and by we,
yes, I wasn't going to really spend a whole lot of time on that vaccine because it's been taken off the market in 2020, and so it's not even an option for people to get anymore.
Right.
So then to move on to that, move on from that, and So a newer version of that shingles vaccine was created in 2017, and it's called Shingrix, Shingrix, Shingrix. And it is used and it's a recombinant DNA. Varicella zoster glycoprotein E antigen. Okay. So it's this glycoprotein E antigen is a main target of what we call the CD4 plus cells, which is it's a T cell. It's part of your immune system. So that helps to generate that immune response. And so they've picked out this piece of the varicella or the herpes zoster virus to create the vaccine.
Yeah, on the picture that we'll post on our Instagram with a picture of a herpes virus, the glycoprotein is essentially the shell on the outside of the virus. So it's essentially the thing that will eventually, it uses to get inside of your cells in the first place. So we're just taking those proteins on the outside of the shell of the herpes virus. And then you just make a whole bunch of those proteins by putting the DNA inside of a yeast, and then the yeast basically churns out a bunch of those proteins, and then you essentially supply those with the people.
So with that, with giving this, injecting this part into your body, this part of this virus into your body, it stimulates your immune system, and you start having active immunity. So it kicks in your immune system, and it helps to protect against Zoster disease because it now starts to recognize this virus, and it's going to have the army, and it's going to, be on guard for attack, so that if they see any parts of it, that it'll get knocked out. And this virus, I mean, oh my gosh, this vaccine, this Shingrix vaccine, is approved for use in people who are 50 years of age and older. And it's also approved, it's just got a recent approval for use in immunocompromised patients 19 years of age and older. So again, remember, those patients with an immune system that's not working correctly are definitely much more at risk of developing shingles. And so this vaccine is approved for use in those patients as well. There is, so a question would be, well, tell me again, who all can get the Shingrix vaccine? And so it's going to be, in addition to people who are over 50 years or people who are immunocompromised and over 19 years of age, you also want to get it if you've actually had the shingles, because you can get the shingles again, even though it's not as likely. But if you've had it once, you probably never want to get it again. You want to make sure, if you're going to get the Shingrix vaccine after you've had the shingles, that you want to make sure that your rash is completely healed over before you get the vaccine.
Yeah, because probably the varicella virus is still inside of your cells. It's just lying dormant again. Right. And so if it does come out of that dormant phase again, you want to have an active defense towards it.
And the other thing, we mentioned the older shingles vaccine, which was called Zostavax. If you happen to be a person between 2006 and 2018 that got Zostavax, and we talked about the fact that its activity dropped over time, and so it was not as effective, then you can get the Shingrix vaccine. You need to wait at least 8 weeks after your last Zostavax dose. But again, that's kind of a moot point now, because Zostavax hasn't been around for 3 years. So anybody who had Zostavax in the past is eligible to get the Shingrix vaccine now. And then also, if you've had the chickenpox vaccine, there is actually a chickenpox vaccine. If I'm not mistaken, that I was trying to look that up, but I forgot to write it down in my notes. I think it was an attenuated live vaccine. I think the chickenpox vaccine is that, but it doesn't protect against shingles. It protects against chickenpox. I know that's weird. I think it has to do with the amount of virus that's in those different vaccines. I think that the amount in the chickenpox vaccine was lower than the one that's in the shingles vaccine. So I think that's the difference. But
it can also be a timing thing, because I'm thinking, because there was a paper I read for this lecture or for this podcast where we were talking about, so they were analyzing. Basically, there was a study done, and it was an observational study of basically looking at 6 million kids who there were some who had gotten vaccinated against chickenpox, and then some who had not gotten vaccinated against chickenpox. And I think the vaccine came out 96? Was it 93?
93.
93.
Mm-hmm.
And so there were people like me who was born in 87 who I didn't get vaccinated, but I did get the chickenpox. So I had some type of natural immunity. I imagine that will wane over time. I'll probably want to get the Shingrix vaccine or whatever the variation is. But the more I think about it, the closer I'm getting to 50. So I'm like, maybe it'll still be around when I'm 50. When I'm 50, that's 15 years away. But they followed this population of children who had gotten the vaccine versus ones who didn't. And they noticed a 72% reduction in herpes zoster incidence, which they basically defined as, they didn't define it as shingles, because I think it was either kids getting chickenpox, or if they had chickenpox, they had some lessened version of shingles. Because remember, kids, their immune systems are just better. So they will actually keep some of these, diseases at bay, or they won't be as severe. We saw this during COVID as well. There's just, it mainly affected older people just, due to, kids being a little bit more on average, their immune systems being more robust. So it was interesting to see that reduction had happened in that population. And I think we were talking about in context with, getting this chickenpox vaccine, it does seem to reduce the incidence of shingles in adolescents.
Right. Because that study went up to 17 years of age. And yes, and so that chickenpox vaccine, works well to prevent chickenpox, or sure, if a kiddo gets chickenpox after they've gotten the vaccine, it's a really mild version of the chickenpox compared to other kids and stuff. So
I should also mention in this study, it was like there were 6 million kids, but the incidence of shingles they had to use a big population because shingles amongst kids is so rare.
So rare.
And so you have to do a large sample size to try to see if it was effective. Because remember, this vaccine's only been around since 1993. So kids haven't gotten old enough yet to really see if this is going to be protective against shingles. It seems to be the case in young kids, but I don't know if that'll be the case,
as they get older, because their immune systems will wane just like everybody else's.
Exactly.
So, because we were all kids once. So,
even
me.
Oh my gosh.
This is before we talk a little bit more about the Shingrix vaccine, let me just tell you another little fun fact about chickenpox and shingles. So, before 1993, most everybody got the chickenpox. Not everybody, but a large percentage of people got the chickenpox. And so with all of us as, as parents or older people that had gotten the chickenpox in the past, because kids, grandkids, great-grandkids would get the chickenpox. So it would continually activate your immune system against the varicella zoster virus. So you would stay kind of immunized or protected against the varicella zoster virus. It didn't mean that you couldn't get shingles, but you had this activation because you were constantly around kiddos in just living life that had either had chickenpox or just getting over chickenpox or whatever. When the vaccine came out, so far fewer kids have active chickenpox. So then as the older adults are not exposed as much to that virus anymore. So our immune systems as an older adult don't get stimulated as much. So our immunity against that varicella zoster virus can go down because of the fact that younger kids got vaccinated against the chickenpox. So it's going to be very interesting. And as Josh said, we do not have the data yet with the younger kids that have gotten vaccinated against chickenpox, if in fact their incidence of varicella will be lower because they maybe the amount of virus that was generated in their body wasn't enough to house enough in the dormant and in the ganglion cells. We have no idea. We just don't know yet and stuff. So
yeah, it's true. It's like the pros and cons of. I remember when I was a school teacher, just like the first week of school, I would just always get sick because the kids would come back, and then kids are disgusting, and so they just
they're not.
Yeah, well, what I mean by that is that they
carry disease.
They get into everything, and then obviously you get sick because probably during the summer, when I was on break, I wasn't around as many people as I am when I'm enclosed in a school environment. So you kind of take for granted like a lot of the pathogens that you're exposed to when you're around a bunch of people. Obviously, you can get a little bit sick, but maybe that baseline is kind of keeping your immune system on track, which is why, you should always have a bunch of friends, so if you're feeling alone and just go out and hang out with people. It's not only good for your social life, it's good for your immune system too.
There you go.
Yeah,
there you go.
Just be careful.
So actually there's no maximum age for getting the Shingrix vaccine either and stuff. So it is a 2-dose series. So that means that you have to get 2 doses of this vaccine. You get the first dose, and then you're going to get the second dose 2 to 6 months after you get the first dose. It's administered intramuscularly in your arm, in your top of your arm, and you can get it in your doctor's office, but a lot of, most pharmacies have a pharmacist that can administer your vaccines now as well too. So that's one that they can give. It does cause some adverse effects. The ones that many patients complain about with this vaccine are it does cause pain, redness, and a little swelling in your arm at the actual injection site. You can take Tylenol for a day or two after you get it. it does go away. You might feel a little feverish or just kind of just not feeling well. After you get it, you could get, and that usually happens in about half of the patients. You can get a headache. You can feel a little sick to your stomach, but it doesn't really last for very long. And and again, those, like I said, those symptoms don't last for very long. You could take some Tylenol to relieve that symptom, but it's so much better than getting the shingles itself, because the shingles will last definitely longer than a day or two. So as a pharmacist, what we've told patients when they are going to plan to get their shingles vaccine, if you have a Monday through Friday job, or whatever your schedule is, get it on a day when the next day you don't have a lot going on, so you can anticipate that you might not feel well for a day. You can and then accommodate that and stuff, so you can get that.
That's good advice. And also, just it's my understanding that when you do get those kind of feverish symptoms, that is your immune system kind of kicking in.
It is.
And obviously some people's immune systems are more robust than others, just due to humans being different from one another. So
right.
You're going to get a different response depending on who you are.
Right. Yeah. Right. So this vaccine is very effective.
The
Shingrix, the new Shingrix 2-dose vaccine but you have to get both doses to get the really effective, that's really effective result. In the data that they've collected after they studied this vaccine, I believe correct me if I'm wrong, Josh, I think it was 30,000 patients that did one study. And the overall effectiveness was 97%, 94%.
It was up there.
And that was around a 5-year time period. And that effect has been sustained over at least 8 years. But as time has gone on, the effect has not dropped that much. And the cool thing that makes this newer vaccine, the Shingrix vaccine, better than the older Zostavax vaccine, is that the effects are maintained in the different age groups. And again, remember, older patients are going to be more likely to get shingles. So we're looking at those that are older, the 50 to 59, the 60 to 69, the 70 to 79, and those are over 80. And it's effective in all of those age groups. I believe that it may dump down a little bit or drop down a little bit to maybe 85, 86% of efficacy in those older than 80, but that's still really effective for a vaccine. So that, and it's likely with you, if you get, so again, you get this vaccine when you turn 50 or close after 50, and it's likely that the effectiveness of this vaccine will last, for the rest of your life. There may be, in years to come, that you might have to get a booster dose, but that hasn't been shown yet.
Yeah.
But it hasn't been out long enough yet, really, to know whether or not that's really
it was just made in 2017.
2017. So we don't know that yet. So, but again, right now they know that it probably lasts for at least 10 to 15 years and stuff.
And let's just revisit probability again. So we have a patient sample size of 30,000 people, right? Let's just assume that that's the number of people who got the dose of the vaccine. Let's just assume it's 95% effective at reducing the incidence of shingles, meaning that you won't show the symptoms that we talked about earlier. That still means that there are about 1,500 people out of that 30,000 who will show symptoms, so it doesn't mean. So when we say the vaccine is effective, we're meaning it's effective against non-treatment, or like if you don't get the vaccine. So, but there's still a chance that you could get it. So all we're doing is evaluating risk. So there is a possibility that you could be vaccinated and you could still get the shingles. And it just means that for you, for some reason, the vaccine it just didn't take the way it did for the majority of the population. And then you have to move to other treatments, like we talked about, antivirals and pain medications, and maybe a nice oatmeal bath, to make yourself feel better.
Yeah. The other thing that I want to mention too is that you're like thinking, how can it be good for 10 years and the vaccine only came out in 2017? And because researchers can project into the future when they've got certain data as to how it's like a trajectory. It's kind of like how is something going to do over this time period based on what it's done in these first 5 years. And so that's how they can anticipate that it's going to still be effective 5 years from now because it's doing so good right now. And there's no evidence that it's, abruptly dropping off in efficacy. So.
Yeah, I think that's really well said. And it's also good to keep in mind, like weather forecasts. Like weather forecasts are really accurate, I think 3 days out. But if they get 2 weeks out, I think the reliability is maybe a 50-50. It's like a coin flip of what. So if you're looking 2 weeks out in a weather forecast, that's basically saying based on the conditions that we think the weather is going to do, we think it's going to be like this. And obviously, the further you go into the future, it's going to be hard to predict. But the closer you are in your timestamp, the more accurate your forecasting will be, depending on how much information, how good your models are. So anytime we model these things, it's always making certain assumptions, just like with weather forecasting. So this could change over time, but at the information we have right now, based on the first 5 years it's been 6 years now since 2017.
Yes.
Then we see no reason to deviate, but that could always change.
It could change. So again, that's why you've got researchers that are always collecting data. So
are there folks out there who you would caution against either?
I was just going to do that. I was just going to, wow, it's just too cool.
It's like we share genetic material.
So there are a couple of populations that are not going to want to get the shingles vaccine for sure because of the data that have been found or the lack of data. One is if you obviously, and this goes with it taking any medication, any vaccine, if you've had a significant allergic reaction to that particular vaccine, or if you have a severe allergic reaction to any vaccine, you're not going to want to get this vaccine because a lot of vaccines use the same types of fillers, and extra things in them and stuff. And so you're not going to want to get it if you've had an allergic reaction to a vaccine. You don't want to use it if you're pregnant, and primarily because we don't have enough data to know whether or not it's safe or not. And also, as I mentioned earlier, you don't want to get it if you currently have the shingles. You need to wait until the disease is over, and then you can get the vaccine.
Gotcha. Yeah. And I feel that with the pregnancy, that's going to be a pretty small cohort of people,
right?
Because it's for people over 50,
right?
I don't know when women go through menopause, and I think
it just depends. I mean, there have been some women that have been pregnant, at the late 40s, maybe 50 and stuff, but
maybe for immunocompromised women as well, who are earlier than 50,
right?
Yeah, that's fair,
right? So, again, I think that's just about it as far as what I've got to say about the shingles virus and shingles vaccine. I think that. As we mentioned, it's going to be really interesting to follow this through the next several decades to see how the kiddos that were vaccinated with the chickenpox vaccine, how they fare in the future as far as the development of shingles. So that's just something to stay tuned for. So
I agree. And the wild thing is that there are so many, other than varicella, there's just viruses inside of your body that you just don't even know about and are waiting to come about and do their thing at a later course in time. It's pretty interesting to think that probably everyone is walking around now with varicella or Epstein-Barr virus or some of these viruses that don't have obvious pathogenicity, and at some point it comes out. So when that happens, we hope that you've listened to this episode to learn about some treatments that you can take, and hopefully y'all will go out and, if you're 50 or older, get the Shingrix vaccine and to protect yourself because, shingles is no walk on the beach. It is a pretty awful condition.
And like Josh said, I mean, the vaccine is, and people, it varies as to the effect, but like most people, the effect, the adverse events associated with the vaccine are gone within a couple of days. And it's just so worth it not to have that fear of getting shingles or the post-traumatic neuralgia.
Keep that varicella at bay.
Yeah.
So with that being said, thank you all so much again for joining us. If you like what we do, please share this podcast with somebody else who you think would be interested in learning about biology and drugs and all that fun stuff. Like our Instagram page so that you can follow us. But until next time, my name's Josh Klaus.
And I'm Jennifer Seltzer.
This has been another episode of Your Mom on Drugs. We'll see y'all next time.